So this is what has not been
told.
yet. So just that.
So as a nurse, shall I be like, I've just been having a look at his notes and that he doesn't know about the results or something?
just like I'm not sure how much he does know.
Okay. Yeah. John.
Do you want
Shall
that
I
down?
say,
Or you
I've
can
just
be-
read an MRI report and he hasn't.
Yeah, but don't worry about it.
I'll put that down. It'll
Yeah.
all go down, but then I'll sit you back up. Because the doctor might sit on the bed with you.
Yeah.
Ready?
Sorry, Ash, I'm playing around with the bed.
Fine.
Is that alright, love? Hey, so what have we got on tonight then? We've got the little one, haven't we? We've got to take her to ballet class, haven't we? And then, yeah. And then what about little Robbie? What we're doing with him?
Oh my god. Might turn on to get some food.
I'm gonna leave that
but I'll just have it first.
Right, okay.
Let's have a quick look.
Yeah, of course, yeah.
So then holidays,
Yeah.
where are we going?
Of course, do whatever you need to do.
Well, I like to look at the one in Spain, but
That villa?
yeah.
I know, but it's got a swimming pool and the kids are, well, the little aren't there? I mean, the young un, he'll just have to be in a bloody
Hi
life jacket.
Hi, sorry, just wanted to
No,
know.
it
Is doctor's here now. I was going to just come and have a chat with you. Was it? What's your relation?
Oh, I'm his wife.
Oh, you're his wife.
Yeah,
Right, lovely.
yeah,
Good.
yeah.
I'll just let the doctor know that you're both ready for him to come and have a chat.
Yeah,
All
yeah.
right, are you okay?
We'll be home soon. We'll
Yeah.
grab some shopping on the way
Okay,
home. Yeah, yeah.
What's
Okay. Fancy a Mackie D? Burger King.
Yeah.
Right. Okay. Yeah. Yeah. God, the doctor's scruffy, isn't he? I mean, working jeans. You wouldn't think so, would you? You'd think he'd like. It's these young
exam.
Yeah. These U's. That's how you know when you're getting older, isn't it? Right? The doctors and the police are getting younger. Yeah, and we're getting older. Hey. What are they looking at?
You will do in 1 second.
All right, okay, doctor.
Zoom this out.
So Spain, right. I think we should get it booked before the prices go up.
Yeah, because they're gonna show up.
Yeah,
So
yeah.
just,
And we need to go on holiday before the kids start school
yes.
because otherwise it's just going to be mega expensive.
Chaos as well.
Yeah. Yeah. Did your mum buy you them socks for Christmas?
Yeah, she did.
Just,
Yeah.
I tell you what,
Absolutely.
your mum buys you some strange things, doesn't she? Eh?
Well, I wore them for.
Yeah.
Church.
Yeah. Can I do anything? Or?
Jesus for that whole thing.
Oh, that's yeah.
No worries, I'll crack on with someone else. Yeah.
Hi, good morning.
Hello there.
Sorry, I can't sit down with this. Okay, apologies. My name's Mickey. I'm one of the doctors working this evening. Could you just confirm your name?
Ashley.
Ashley. Lovely to meet you, Ashley. And who have you got with you?
It's my wife.
Nice to meet you both. Okay.
Hiya.
So, first of all, I think it's quite good to explore what's brought you in. What do you understand about what's brought you into hospital?
Um,
It was months ago, wasn't it?
yeah,
Where is it?
it was.
There. I mean, you've still got a little.
Yeah, I procedure done, but
It was a little cyst, wasn't it? You had
Yeah.
removed and.
yeah, it was just a little cyst.
Okay. Sure. And what's brought you back today?
Um,
Bit embarrassing, isn't it?
well, I haven't been able to weed properly, and I haven't been able to feel down below.
Okay.
So, like,
He can't get an erection.
Yeah.
Okay.
at
Sure.
all.
Okay.
Yeah.
And whilst you've been here today, I know they've done a couple of tests. Is that right?
Yeah, I think I've had a CT scan.
Yeah.
I think
All over it, yeah? Yeah.
Yeah. I think
Yeah.
I've got a few what's done.
I know you've just been for an MRI as well. Is that right?
Yeah.
Yeah. And what do you understand about why these tests were ordered?
I think they said something about being some spots on, I think on my back or on my spine or somewhere. But I'm not really too sure.
Okay.
But you feel fine, don't
Yeah, I
you?
feel
Yeah.
fine.
Yeah.
Yeah.
Okay. So, The results from the MRI scan are back, and I can tell you about them. But before I do, because of the results, I just want to make sure, is there anybody else you'd want around to be told these results? Or is this, are we in a cubicle? Is this private? Yeah. Yeah, okay.
I'm not too sure what is someone from the results.
Well,
I'm happy with my wife.
yeah, is that okay?
Yeah.
Sure. So, as you said, we know that a few months ago you had the obviously procedure to remove on your arm, and you've come in today with obviously the symptoms that you have, and the worry would be that when people present with the sort of change in sensation and erectile dysfunction, that something would be happening with the spinal cord. And when they did the CT earlier, obviously that's when they found, as you mentioned, those spots. And this MRI was ordered just to get a little bit more information about that.
Yeah.
And the MRI does show that there are some masses pressing into the spinal cord.
So what does that mean then? What does that mean?
So at this point, we're not exactly sure. It could. Essentially, we need more investigations, and we need to discuss it with the experts in this case, who would be the spinal team, to find out exactly what that means. But what we do know is that these masses are pressing into the spinal cord, and that's what's causing these symptoms that you discussed.
So where's the masses come from then?
So again, it could be multiple things, and without further investigations and discussions with the relevant teams, it's hard to say for sure. It could represent something, obviously, well, it could represent something sinister.
Cancer, is it?
There is a possibility that it could be as a result of the spread of cancer. We don't know for sure at the moment, but we'll discuss it with the relevant teams.
You alright, love?
Yeah.
Oh God.
Am I gonna die? Or
Well.
Oh gosh. I can't take that. I mean, if we've got young kids, both under the age of 5, it's just, oh gosh.
I appreciate this is difficult news to hear, and I'm sorry to have to tell you in this way.
But he's fine. He looks fine. You've been doing everything, haven't you? You've been at work this morning. No, there must be a mistake. There must be.
Well, I appreciate this is a lot to hear at the moment. In terms of things like what's going to happen next and how things will go, we'll need a little bit more information before we can tell you a bit more information, essentially. What's going to happen now is we're going to go and have a chat with the team from the spinal team.
Okay.
We'll discuss what we found, and we'll ask them for their advice. They are the experts in this case, and what happens next, what investigations we need to do.
I'm sorry, I can't take it in.
Yeah.
I can't take it in. So you're going to speak to somebody and then see from there. Is that speak to a specialist?
That is, yeah, at the moment that is the plan.
Do you want to ask any questions, love?
So have I got like a certain amount of time to live, or
No, don't go down that route. What about treatment? Could you have an operation to get them removed? And
These are the conversations that we'll be having with the spinal team when we discuss them, is what do they think can be done. Unfortunately, whilst I'm here, I don't want to say too much, because without that discussion with the experts, I want to be completely informed with the full details of what's going on before I mention anything like that. But I thought it was important for you both to know exactly what we think the scan showed and exactly what we're doing about it. I appreciate this is a lot to take in. Is there anything I can get for you at the moment?
Some water.
Some water. Would you be able to get some water? And some water?
Yes, some water.
Is that okay? Thank you very much.
I think this should be a minute or two as well.
No, of course.
yeah. Thank you, doctor.
So we're here all the time. Obviously, I appreciate when things like this happen, or when you're told things like this, it can be quite difficult to think of questions on the spot. If I go away and think of anything, feel more than free just to ask me.
Yeah.
And I can come back and answer as best as I can. And of course, as soon as we have these discussions and we have a bit more of an idea about what's going on, we'll come back and let you know immediately.
Okay, did you want to drink off? Okay, thank you.
Sure. Well, I'll give you a little minute, okay? Thank you very much. Cheers.
What's happened?
I couldn't hear everything.
Oh, sure.
Because it's so busy. What's going on?
So, obviously, the scan was ordered to rule out things like compassion and things like that. And the MRI does show that there are masses pressing into the cord. What these represent, we're not exactly sure yet.
Okay.
But we'll be discussing it with the spinal team and we'll come back. I think they're a bit emotional at the moment. So
Understandable. I didn't think they knew this would come in,
no,
When I first spoke to them, they didn't have any idea.
but I think that we need a bit of attention at the minute. So
Yeah.
would you be able just to come back and I'm happy to tell you.
I think we would all. I actually want to tell you that you can't. Mickey, that was pretty much perfect.
Yeah.
Wow.
Yeah.
Okay.
Spot on.
That's nice. How do you feel about that?
I don't know.
It's like, how do I sound modest without saying that
I feel
I was
It was difficult, obviously, like when I was trying to figure out what was going on, hearing them talking about going to Spain and things like that.
Yeah.
Yeah.
You had to go in there and ruin it. So
I know.
But he did it so nicely. Don't you think he was just so kind and empathetic? Nobody is agreeing with me, but I
I thought it did very
Very clear communication as well. I thought it was really easy to follow.
He did a really good warning shot as well. Sorry to interrupt, Will.
Body language?
Yeah, I was going to say non-verbal communication is really good. Like, you got yourself a chair and set up and did everything nicely. I liked that you addressed the patient and the wife before you even went over as well. So it didn't look like you were ignoring them. Like, really, really early on. Thought a nice bit of rapport.
I felt included
Yeah.
in the conversation.
I think it's good that he gained like the patient understanding first.
It's like the spikes framework, isn't it? Like seeking information and what the patient already knows and all of that.
I think he used silence quite well, like you did in terms of process. I think it was good that you checked that everyone who needed to be there was there.
Yes.
That was a warning shot in itself.
Yeah.
And the environment as well.
excellent job of making sure it's private.
Yeah.
What was I saying? An excellent job of making sure it's private, clarifying if there was a cubicle or both.
Yeah.
Was there anything else in terms of challenge?
Nah, he's spot on, honestly.
Maybe patient understanding.
Yeah.
When that procedures removed the cyst.
Yeah.
Yeah.
Clarified that it was melanoma.
Yeah, what was that understanding of actually what had been going on before?
Yeah.
Did he actually have a scar?
Yeah.
Yeah.
No, not for real.
Was it drawn on? Yeah.
Yeah, drawn on. But subtlety is everything with mirage, so it doesn't have to look all gnarly. It's just like a faded pink mark.
Another challenge would be like a bit of the unknown. You're not telling the patient you definitely have cancer, you're not telling
Yeah.
them this is definitely the path that the surgeons will take.
And then limitations of your expertise as well. But I think you dealt with that really well by explaining that you aren't going to be able to give them all the answers.
That's debrief's going to be easy.
Yeah.
You left the door open as well, saying very overwhelming, probably have more questions. If you need anything, let the nurse know, you should go get them.
We all thoroughly enjoyed the, is there anything we can get you? Yeah, a glass of water. Can you get that glass of water? That's such a doctor move, isn't it? Is there anything we can do to help? Nurses, can you go and do that?
Good. Chances are they're already stood there with their head tilt in the tissues anyway.
Yeah.
Yeah. Anybody work in palliative care? I need to do anything.
I'm in haematology oncology at the moment.
Ah, yes.
So there's a lot.
How's your head tilt? You don't,
I've just become self-aware of that right now.
Yeah. Okay, so now there's so much, but obviously the big one here is the spikes, isn't it? And so I think, because a lot of this feeds into that. We'll look at this and more limitations. Okay, I'm sure most of you have done some kind of breaking bad news at this point. Who hasn't? Okay, most of you have done some. Okay, right. And have you had any where it's been a challenge? Hard. Right, good. Anything, yeah.
The nighttime calls that like a family member is dying, those are always the hard ones, because people aren't expecting a call normally. That somebody's deteriorating quite rapidly. That's when
How does it make you feel? Because we're going to talk about spikes in a bit, but like, how does it make you feel?
very proud.
Proud?
Guilty.
Guilty? Right.
I think if you do a good job, it can also be one of the most rewarding things that you do as a doctor.
What is it about doing a good job?
Knowing that you're leaving people with some clarity, that you've made a very difficult time easier for them to digest and process, because you can't really take away the pain of what's happening. But you can make things just a little bit easier for them in that moment, and also as things progress, especially where I am and there's that continuity and they're there to communicate every day. I think it's really rewarding kind of hearing feedback saying that actually your communication helped me understand what was happening. It helped me process what was happening, and I think obviously those nighttime ones can be really difficult when you're on A&U and it's over the phone, and I don't always think it's entirely appropriate. I always, if you can get people in, I try and get people in. If you can't, then unfortunately you just have to do it over the phone. However, like what Mickey did, that one where you get to sit people down, get that privacy, get to address their concerns. I think although in the moment it can be very scary, you don't know how someone's going to react, it can be angry sometimes, and that's a human reaction as well. If you have something that goes as smoothly as that, you do walk away from it feeling like you've done something really important for someone.
I feel like once you've seen Breaking Bad news done really badly, I feel like in a way that was almost a better learning experience, because you learn how not to do it and how you would not want to receive that news. And like I was just saying to Peter before, that I, as a medical student, I had a breast surgery placement, and the consultant was basically seeing a woman for her final like post operative 5-year review, where she was hopefully going to get the all clear. She had the CT the day before and a mammogram, and we found a new mass that was more invasive than her previous ones. She was probably going to be made palliative. She was only 42, she had 3 young children below 15, and she was expecting to get the all clear because it was 5 years and all the surveillance scans had been fine. She walked in, she just sat down, and the consultant looked at her and said, right, you have cancer. And that was it, that was the whole thing. And she didn't even cry, she just started screaming because she was so, like, she was wailing, and I was just sat in the room like, I don't want to be here, she doesn't want to be here. He was getting up to leave to get the nurse to look after her, and I was like, this is just the most inappropriate way that you could have done this. You absolutely just destroyed this woman's life without any even, like, just any thought for how she was feeling. So seeing something like that is really, it's quite inspiring really, that like the juniors are so good at it. Obviously this is simulation and like it's there to make mistakes and learn, but knowing that you can do it properly is, I think, it is really satisfying. And that's what the patients will remember.
That's it, because you only get one shot at it.
Exactly, and once you mess it up, that's it. You kind of ruin the relationship between the patient and seeking healthcare, because they're not interested if the doctors, nurses, whoever are going to be unempathetic and not receptive to how they're feeling. Because for us, okay, it's a bit grim at the moment, and then 15 minutes later we've got to go and look after another patient. It doesn't matter, but they have to live with that. So
Wonderfully put, because I had a final year medical student not so long ago. And I went, breaking bad news. I already know breaking bad news. And I was like,
oh god.
there are some things that, because I've seen so many different scenarios, been involved in so many different scenarios, I thought, just because you do it once well, doesn't mean that you've got that licked.
Yeah.
Because every different scenario is a challenge, isn't it? I remember one. This did happen. I know this sounds like one of my jokes. It's not. It's absolutely true. This was back when we didn't have the trauma, the transplant coordinators who do such an amazing job now. And I was in there with consultants, and I said, "Do you want me to?" Yeah, you do it. And I'll get service. So I broached it, and this family. They were not the brightest bulbs in the box, I have to say. But at the end of the day, also, this was their son. A horrible situation. And I explained to them that he was brainstem dead, and that was the result of the second set of tests. And then they said to me, "Can't he just have a brain transplant?" And I was like, how do I you know, when you saw, like, was not expecting that. I think I said something like,
No.
we can't do that. His brainstem dead, which means he's gone, and there's nothing we can do. But actually, you know, when you're like, it just derails you, and you think, what do I do with that? So every situation is unique, isn't it? What's the damage? And I know you mentioned that it ruins lives and everything, but what's the damage of doing it badly?
Or you just lose that relationship with the patient.
Lose relationship? Anything else?
It's not just your relationship, is it? It's like
It's healthcare. It's the
their
patient
relationship with the like entire NHS and any future information that's given to them. You leave them with, like, you don't know if you're on an evening shift. It might be a Friday. You could leave them in uncertainty for days on end.
Yeah. And that's interesting, because when you look at the SEIPS model, SEIPS, which is all to do with human factors, that's one of the later things I'm covering. SEIPS is like your relationship with the individual, but also with the wider NHS, and how much you can erode people's trust. But when they're dealing with grief, what's the impact on their grief response? You know, those who are left behind. How are they going
Trauma.
Trauma.
You can actually give someone PTSD when you
Yeah.
bad news properly.
absolutely been
So my background is working in the medical examiner service, and most of the complaints are how that news was given to them, that their loved one, or they'd mess the funeral arrangements up, or paperwork being late, and it was always how the doctor had explained it. That was the number one complaint.
So what you said is on the money, in that you can do it well. You're not going to shield it from it, but you can do it well. That you can't shield it from it, but you can stop it from being any worse. So, you know, it's on you at that point. And it's a tremendous responsibility, and dare I say, a privilege, you know, in a way. So, I have to say, that's the best one I've seen done and said. You know, that's it. Literally perfect.
It was very well
There's
done.
one or two minor things, but absolutely stunningly well. So did you have a process in mind? Were you thinking Spikes, or were you just kind of coming in?
what Spikes did.
Wow.
I think you inadvertently did follow it.
Yeah, especially in my A&E, I'd seen quite a lot.
Uh-huh.
So I don't know, I feel like I've been involved in a few of them. Just
Okay.
copy mobbed them. Obviously, not just they all seen other people doing that.
Yeah. But you do, don't you? It could be, I think 90% of the stuff in my toolbox I've nicked from other people. And that's a great example of it, isn't it? So let's break it down. If we're going to think about sort of space in terms of like the situation, what did you do initially? Because it's all on here, isn't it?
Check that it was a private environment.
Check it's
whoever
private.
That he had the people that he wanted with him.
Yeah. Also, make sure you check it's the right patient. I have seen Breaking Bad used done with the wrong patient. Twice, actually.
So like they
Not
told
the
the
same
wrong patient
patient.
that they had cancer.
Yeah.
Okay.
They were over the moon when we said there'd been a mistake.
Yeah.
They didn't make a complaint, but they could have done. The second one didn't either. But so it's all that kind of setting your stall up, isn't it? What are the things in terms of preparation?
You ensured that you had the knowledge. You didn't go blindly, like you looked
Yes,
through the notes and made sure.
Making sure, detail. Yeah. Anything else?
He introduced himself to everybody.
Yeah, just general introductions. And just making sure you get rid of your distractions, get rid of your devices, give them somebody else temporarily if you have to. And that includes their personal mobile phone as well. Keep them shape. I'll be back in a minute. Get that room ready and be ready. Also, sometimes depending on where you are, you might want to take resources in with you. Like for example, if you work in hematology or someone, or you work in those kinds of areas, there might be leaflets and things that you can take in with you, or you might take a computer on wheels in with you so you can show them the scan and show them whatever. So
all the cancer nurses sometimes like to be involved right from the beginning.
Critical, because they can mop up while you leave. How much of that do you think the patient's taken in when you start?
Well, I suppose if you take one of the nurse specialists in with you as well, it acts as a bit of a warning shot sometimes that you might, and it sort of gives them the impression that it might be a slightly more challenging conversation.
I think once you say cancer,
They start listening.
my brain would shut off and I would suddenly immediately start thinking of all the things I haven't done and all the things I wanted to do. Like I know myself and I imagine a lot of people.
Absolutely. So it's just from that point of view, they go into shock mode and they'll probably start taking in maybe 20-30% of what you say. I've had patients relatives swear blind we've said something when we haven't, and I know because I've been there and working in ICU, you see that quite a lot. But we didn't say that. It's just they're trying to half remember and then they make up the rest. So it's a really good idea to have another person in with you. So the kind of situation, the perception bit, beautiful example I thought. What do you think?
Going to explain it, and then you recap as well.
When you're getting his, you're thinking, makes your job that much harder, isn't it? So anything else in terms of perceptions?
I think Sarah said that something about cyst, and I think you did a really good job of clearing that up later on. I think you could have cleared it up in the moment, as some people have said, but I think also it might have been a little bit too much at that time to say actually that's a cancer, in that moment. So I think the flow went really well.
So you're kind of getting their terminology and their terms. So kind of helps you align to that, isn't it? Because you think, right, okay, I think I know where I'm coming from here. And the best thing about perception is this is your easiest win in this dialogue. Okay, how do you know you're being listened to?
Someone can repeat back what you said.
Someone can repeat back. Yeah. So paraphrasing. We already talked about the non-verbals, right? So if somebody's listening to you, you're more inclined to want to communicate with them more, so you build in the rapport, isn't it? Okay. So the perception is the easy bit because you ask a few open questions and you just kind of hang back, soak it all up, encouraging, paraphrase a few things back, and then you're building up a nice rapport. So when you get to the later bits, that's going to pay you back. Yeah. So you get to the invitation bit. Now the invitation bit I think is a bit that people struggle with probably the most. What do you think the invitation was all about? Because I think you did some of it. What do you think that's all about?
It's like obtaining, it's almost like inviting them to tell you that it's okay to carry on with the conversation.
That's a lovely way to put it.
Yeah.
Yeah.
I don't know. I don't know how other people feel, but I sometimes feel it feels a little bit like a bit clunky.
Yeah.
Because obviously the patient,
Yeah.
most of the time patients are like, yeah, why would you stop? I want to know what's going on.
Yeah.
But you know, everyone's different, so obviously it's good to have that barrier so that they can sort of understand and appreciate. Actually, yeah, you know what? I do need more people, and I'm getting the impression that something serious is going on. I'm not ready to hear it. I want X and Y, Z to be here with me, or I need an interpreter, or whatever it is. Yeah.
It can feel clunky at first, but you already did one aspect of it. What did he ask about relatives? Did you want anybody else there with you? Blah blah blah. So you're already kind of got a foray in there, and like you said, that's literally a warning shot on its own. How can you broach that you're going to give them sensitive information so they've got a decision of whether or not they want to hear it? Because whose information is it?
Theirs.
It's theirs. Do they have a right to decide whether they want to hear that information or not?
Yeah.
Yeah. I had a cousin, he's gone now. He said to me, John, I didn't want to hear it. I wasn't ready. I know I needed to hear it at some point. I just wasn't ready then. I just thought, just give me another week. I just want a week where I don't. And he said, nobody asked, they just told me, and he wasn't ready. And this is never going to be an easy time, I guess, but I didn't want to hear it then. Have you ever had any old days where you started to talk to them about it? Have you ever had anybody that hasn't wanted to know?
Yes.
Yeah.
You have?
Yeah.
Is anything
So this was I think a known lung cancer. She was coming in with repeated chest infections. She was not that elderly. When I made it aware that this was not going to be a pleasant conversation that I needed to have, and I said that there are a bit more difficult things to be talked about as well.
Nice way to put it.
Yeah, she immediately stopped me and she was like, I don't want to hear it now. Then I was like, okay, fine. Then let's talk about what we can do for you right now,
Great.
and then we'll take it from there. Because she was right there in A&E. Yeah, it's a very acute setting. Yeah, she's seen so many people all at once. And I think she said, she acknowledged the fact that this conversation is something that she needs to have. So she pointed out that to me later on when I was setting up the oxygen and everything else. She pointed that out to me. I know I am not ready for it, but I'm ready for my spouse to do it. And I was like, okay, fine, we can do that. And she said, not near me, please.
Yeah.
So yeah.
So what do you do then because let's say you might need to give them steroids, or you might need to refer them to a spinal team. How are you going to broach that without?
Yeah.
Just laying out all of the sort of options, but provisionally. So you're like, because it's clear in that circumstance that there's a diagnosis there, isn't there?
Yeah.
So you've got to sort of lay it out and see what they would want, if they actually want any treatment at all. Because if they say, actually, I'm not interested in having any investigation or any treatment for this, then you don't even have to even broach that side of things.
Yeah.
And then you can sort of lay out without putting into words like what treatments they would or wouldn't want in a sort of DNR-esque discussion. And you can find up the ceilings of what limitation of care. And if they want to know what you're doing individually, then they can ask. Or you can just crack on with like still.
What you need to do individually. So you can say
like in terms of like individual,
Yeah.
like so you could say like this is one of the treatments for steroids, for example. You could say this is something that we think might help with some of the symptoms that you're experiencing.
That's exactly.
And you can demonstrate the side effects that they might have and the risks and benefits of it without necessarily saying what it's treating or why.
And it's the same thing with spinal team. So okay, the spinal team are going to help us with it. You don't need to get into it. Because so they can still have an element of informed consent, just with the bits that they don't want to know about. So it's doable. It just feels odd. But now, and the thing is, you're probably going to need to have that conversation with them, probably before the relative is there, because they might not want the relative there. Have you got any thoughts about how you handle that? Because suppose there's already somebody sat there.
I had a patient come in with likely renal cancer, but she didn't want a CT scan. She was just essentially pissing an insane amount of blood and coming in with bleeding like HBs, the 3 that are transfusions. she didn't want any scans and she didn't want her family to know, which was really difficult. And she didn't, like, we 2 weeks waited her initially with her consent and she didn't go to any of the scan, like any of the appointments or any of the scans or anything like that. So it was really difficult because the family could see that she was deteriorating. But we were having regular kind of, because this isn't GP, so we were like calling her regularly to be like, your HB is low, I need you to go to SEC and get transfusion. It's like really tricky, but you can't really do anything if the patient doesn't give you consent. All you can say is, you know, I'm sorry that you wanted to know. She's expressed that she doesn't want to talk about this. You need to ask her, but I can't say more.
It's awkward, isn't it?
Yeah.
I think if they've got power of attorney and stuff like that, it's slightly different.
I was just going to say, this is, you know, like Will mentioned earlier, that things like this make him feel guilty. And I think this is a time when I feel really guilty because, you know, often you see that when families are supportive of like a loved one's care, it becomes like holistically better for them. And you're like, well, this is what they want, but it's not necessarily might not necessarily be what's best for them. And it is quite difficult then because you're like, well, I know that X person's daughter or son wants to know what's going on, and we just have to say, sorry, legally they said that they don't consent to sharing the information, I can't give it to you, and you just feel, I find that quite difficult.
And make sure it's documented, because that often come out in the medical examiners when they rang the relatives, and we can go back to them, well, it was actually documented that it was her wishes, she didn't want the family to be aware.
Yeah.
It's awkward. I think the best time, one of the ways I've approached it in the past is I've just said, we're just going to do a quick examination, just a quick look at them. We just actually step out for a minute and then get them somewhere else, not with an earshot, because you know those soundproof curtains don't really work, do they? And then once you say them, look, do the invitation bit that we've already talked about, and just say, look, if we have to have a different conversation, who would you like to be, if there is bad news involved, who do you want to be with you? And you know, and sometimes they will say, I'll tell them in my own time. And then that's one of the ways I've tried it. But you know, there's lots of different ways you can approach that. So that's anyway, invitation. The other bit was knowledge. So you've got their perceptions. And what did he do that was so really good in terms of linking the knowledge bit space to perceptions?
Like guided him through, didn't you, from his perspective?
Yeah.
And you created a narrative.
Yeah.
That you knew that they could follow because they explained it to you.
Yeah, you knew they could follow. So you were things they were saying. You went, well, when you said this, and then you moved it on. That's called alignment. Taking something they've said, paraphrasing it back to them and going, and what this means is, and then putting your spin on it, which is exactly what you did. And it's beautifully done. What about did you use any jargon or any terminology? No? Yeah? Great. Even if you've got somebody who's an expert person, like maybe it's like a critical care nurse you give bad news to, you can't just assume, because if they're in shock mode, I've seen people go, where you've said to them, well, so we're thinking about palliative care decisions. And they'll walk away going, yeah, but she's not dead yet, she's not dying really, they're just going to maybe take her to hospice or something like that. And you're thinking, no, we're talking about the pathway, palliative care pathway. So you need a care of the dying pathway is maybe the better way of phrasing. So it's all about the words, isn't it, terminology, but you didn't do anything. Do you use any tools to help you with the knowledge bit? Sorry, with the information given the knowledge bit.
I think it's like a chunk and check.
Chunk and check. Nice. Yeah. Stop. Reassess. Move forward. Yeah. And this is the bit where you can bring those adjuncts in if you need, and just go explain. If you can lead them with notes and stuff like that, that's really, really handy. They get an emotional response. If they freak out, scream, get angry, start kicking stuff, what do you do then?
There's no point progressing with the conversation, they're not ready to hear it, so
Absolutely.
I think it's important to acknowledge how they're feeling and then say, obviously, you know, you're in a bit of a state of shock, I think I'm going to give you a bit of time to come back in half an hour or whatever.
What did you do really well when they had an emotional display then?
Waited.
It's awful, but you've just got to shut the hell up. And it's so very easy to leap in with a platitude, isn't it? Because we're human beings and we kind of want to go the version of there, but it's not really helpful at that point. You just got to sit there and kind of. I don't know how long you would leave it. It varies, depends on the situation. Obviously, you haven't sat there for half an hour and so, you know, that's a bit weird. Give them a minute or two, you know, just, you know, and then maybe interject a little bit, just about how you're moving things on. But you did that really well, didn't you? Because you've got to move on to the summary bit, and that depends where you work and whether this, you know, if you're in an emergency care area, you're not going to be doing all the aftercare. You're not going to be doing the specialist spinal care for the patient, so you can't really give them all the bits. But if you are on a haematology ward where the end care is going to be delivered there, you might have the speciality to then proceed with the expertise giving. Because I don't know if any of you have looked at the Gawande stuff on the spikes. I don't know if he talks a lot about what the patient wants, you know. Because if you're working in an area where you're going to give the terminal care, you kind of want to know a lot about what the patient wants and what that needs to look like, don't you? Like my mum, for example, she wanted a diet at home that was very important for her. My dad, he wanted to be pain-free. And it's all sort of, you tailor it, don't you? But you can't do that in this scenario because the patient's going on spinal. So what did he do in terms of summarising things?
I explained where we're at, I suppose.
Yeah.
And just like gave a clear plan.
A clear plan.
Okay.
This is what I'm going to do. This is the limits of my knowledge. This is what the next steps are. And I suppose you can offer to come back. But if you're going to do, stick to it.
I like to ask them to write down, which is helpful before, is like write down any questions that they have, because
Right.
we never ask them straight away. But
Yeah.
then, like when you come back the next day, sometimes I've written questions that I can try and find out for them throughout the next day. There's also really good resources in the Macmillan Centre, which is next to the outpatient department, which I didn't know about until this week. But they've got like booklets on helping patients understand the diagnosis. So if you've got a difficult one coming up, you can take that with you in preparation and maybe in the
All right. I take it you're all reasonably happy about Cora Aquina. Yeah. All right. So take to practice messages. Anything in particular?
do what Mickey does.
Be like Mickey.
There are different tools out there, but it's as good as any. Yeah.
I think using silence as a tool.
I use it a lot, even doing this. Because the thing is, the more you talk, the less they're thinking. And they could be thinking about all sorts, and you jump in and interject and totally derails them. You know?
Giving her perspective is
Sorry, say it.
like giving her commands, like some respect and treating space and limits.
Go ahead.
Steps.
Give me an example.
Like acknowledging that it's difficult for me, like trying to keep
Yeah.
patience.
This ties in to what we were saying earlier about it's possible to do a bad job and do damage with it. Okay, one more before lunch, so if we aim for like a 12:30 lunch, that will probably work.
Yeah.
So should we get the next one done? Are you happy with that?
Can we do the next one?
Yeah, go for it.
Please.
I
just want to do my scenario.
Just give us a
I'm gonna have
moment in case I need to do any.
I do my scenario, and I'm gonna be fine.
I'm just confused, isn't it?
It's awful. It's mine.